Hi, good afternoon. If you can just write down your first and last name onto the chat, it will be used for attendance purposes only. Thank you.
Good afternoon, everyone. We'll get started in a few minutes. Okay, I think we should be all set to begin. Claudia, I'll pass it over to you for any introductions for today. I know Senator Marr is still in session and Rep. Exum is unable to join us this afternoon.
All right, well, welcome everyone. Appreciate everyone spending some time together. We have a pretty robust agenda, and I know that there's legislative updates. Emily, did you want me to give a quick update on Solnit at this time, or does
Yeah,
that
you can
work?
do it
Okay,
now.
great. Thank you. So I do want to recognize that today is not just tax day, but it's also a consequential day, I think, in an inflection point for what I believe to be very exciting news. And that's a transition of Solnit as of midnight. So at the very beginning of today, 50 long-term psychiatric hospital inpatient beds for adolescents between 13 and 17 transitioned from DCF to a unit of John Dempsey Hospital under their licensure at UConn. And I think that's really exciting for a number of reasons, primarily being that we have an opportunity here to really lead in some of our behavioral health systems gaps. And in partnership with UConn, I'm hopeful that we're going to have some additional ability to recruit nurses and clinical staff. DCF's Solnit facility will have access to some of the best specialists in a broader, bigger, larger psychiatric department. And there's going to be an intentional opportunity to work between DCF and UConn in the short term to make that transition as seamless and smooth to patient care, the patients and the families that are served. I know that all of you will probably have a lot of questions. I want to acknowledge that some of that stuff is still being worked through, but continued conversations and collaborations happen across OPM, the entire executive branch, and UConn Health to make sure that our North Star, the goal that we all care so deeply about at TCB, about additional lift and capacity for our behavioral health system and better throughput in our emergency department care in long-term stays and ultimately return and safe community placement are front and center through this process. We've committed to taking in questions. So as all of you are connected to multiple stakeholder groups and may have questions with unique perspective on this transition, we invite you to share those questions via Tao through Emily. We're committed to gathering those. A lot of those I suspect we've heard already and are putting together an FAQ, but anything that's new and in addition we'll add to that running FAQ and make that available to this group in the next several weeks. We also are committed to bringing together a more intentional and focused conversation to look at some of the early indications of success and how that transition is working in June. So we're targeting a June date for TCB to have UConn Health subject matter experts, DCF subject matter experts, and some of my OPM colleagues to talk through how the Solna transition's working and where we see future opportunities and growth that help our kids and help strengthen our behavioral health system in the state. So thank you, Emily, for allowing me to recognize that important news that's happening today.
Thank you. So I will go forward with the first agenda item, which is the acceptance of the March TCB minutes. Were there any adjustments needed or any feedback from anyone? And if not, can I get a motion to accept the minutes?
Emily, this is Claudio, so moved.
Second.
So move, second, Christina Gio.
Thank you. So I'm now going to go in, as Claudio mentioned, we do have a packed agenda today, so I'm going to briefly provide some administrative updates. So just some work group updates. So next week, the System Infrastructure Subgroup will meet on April 21st from 3 to 4:30 on Zoom. We will be discussing and focusing on a policy paper produced by one of the co-chairs and going through discussion around definitions, system of care history, and policy focus areas. The school-based meeting will be May 4th from 3 to 4:30 on Zoom. Within these school-based meetings, we've been breaking out into different subgroups within the larger work group. So really have been focusing on two as of now, the school billing and special education. Last week, we did have an informational RFQ session that took place in part of the meeting regarding the school billing RFQ. And in the beginning of the school-based meeting, we had Tom Kosker, who we have contracted with at Disability Rights CT, who will be overseeing the scope of work for the special education effort. So we will be reconvening both those subgroups at the May meeting. For prevention, we will be meeting tomorrow from 3 to 4:30, and we'll be having a presentation on the Connecticut Pyramid Model from the Office of Early Childhood. And that work group is also awaiting the results of the CT Children's Behavioral Health Provider Survey, as that will help inform the action items on the work plan. And then for services, those who are on the invite, you might see it was moved to May 27th. At that meeting, we will have Jill Farrell from the Innovations Institute at the Yukon School of Social Work present the data findings from that Children's Behavioral Health Provider Survey. And we are hoping that those results will be able to be presented at the larger TCB meeting in June. So for some brief legislative updates, as you all may be aware, the TCB's bill is House Bill 5447. On March 12th, the Appropriations Committee had a public hearing where this was called. And as of today, the bill has been filed as House Calendar number 433. Any updates to this legislative process, I will send out to both work groups and the larger committee. So I will pass it to Howard quickly to give some updates on his office.
Yeah, thanks, Emily. Just some good news. The Office of the Behavioral Health Advocate, our landing homepage went live last week. So we do now have a presence on the internet and access for the public to reach us. And the better news is that on Friday, 2 new staff will begin as we begin to build out the office. We've hired an assistant behavioral health advocate and a behavioral health associate. Both are licensed clinicians with quite a wide range of experience in mental health, lifespan mental health, both in terms of delivering care as well as managing the insurance component of private practices. So I'm looking forward to introducing them at our next TCB meeting and integrating them into the work that we're doing. So thanks, Emily.
Thank you. So just wanted, before we get into the presentations today, kind of want to level set the meeting last month and next steps going forward. So a lot of you were able to attend last month's meeting, which focused on psychiatric residential treatment facilities, as well as we had Tara on the call present the complex case work group's final report, which highlighted the needs for services for individuals with co-occurring behavioral health concerns and IDDD in ASD. So as a follow-up to that conversation, we have various state agencies presenting on their authority, services, and/or procured services for individuals within that population. Agencies will also highlight their coordination with other agencies and any gaps and barriers. For example, any age restrictions to services, referrals, etc. And next steps, the Talia Justice Institute will be working with the Children's Behavioral Health Implementation Advisory Board to utilize the information obtained in this meeting, as well as some of the work they have been working on to produce some type of informational resource that outlines the roles of state agencies for this population. So hopefully more details will come for this for the May meeting. And with that said, I'm going to pass it over to Tammy, who will kick us off.
Good afternoon, everybody. I'm hoping you can see my screen.
Not yet.
No, not yet.
I have the slides up too, if that's easier.
Okay. I have them up. They're just not sharing for some reason. Okay. If you have them, that's great. Thank you. I appreciate it. So, for those of you who don't know who I am, I'm Tammy Venegay. I'm the Division Director of Children's Services at the Department of Developmental Services. The Department of Developmental Services really mainly serves adults, but we do have a small children's division. So I wanted to do an overall review of what DDS does. So the mission of DDS is to partner with individuals to support that we support them and their families, and to support lifelong planning, and to join with others to create and promote meaningful opportunities for individuals to fully participate as valued members of their community. and by statute, responsible for planning and development and administration of complete, comprehensive, and integrated statewide services for people with intellectual disabilities and persons medically diagnosed of having Prader-Willi. So who's eligible for DDS is through statute, and that is the mission that we have for our agency. The organizational structure, you can go to the next slide, sorry. We have a commissioner, a deputy commissioner, a chief of staff. We have 3 regions, north, west, and south, simple. Southbury is still part of DDS. There's only 85 individuals at Southbury at this time. Their average age is 75. Our central office has specialized divisions, as in we have abuse investigations, business intelligence. Our case manager director is there, even though there's case management and supervisors in all regions. We have the children's division, and just other overall divisions that oversee what DDS does. And then our regional offices have a private division, an individual and family self-determination division, and a public division. So that's what's in the regions. There's approximately 36,500 people in Connecticut that have an intellectual disability. At this time, there are 17,411 that are currently eligible for DDS. Services DDS provides includes public, private, and IFS. And a little over 60% of the people in DDS are supported in their own or in their family home. Eligibility is in statute. So a person has to have an IQ of 69 or below and significant limitations in adaptive functioning or Prader-Willi. Also, the disability has to originate prior to the age of 18. So if we need testing and all of the diagnoses to happen prior to the age of 18. One important note is just because you're eligible for DDS does not mean you're going to get services. This is not an entitlement program. We are limited to within our appropriations. So there are many people that are eligible for DDS that do not get any services. They are on our helplines, they do not have case management, and they do not receive annualized funding. Just what DDS is not, we are not a child welfare agency. I think sometimes that gets confusing because we did open a small children's division. We do not offer family-centered programs. We are a waivered service. So we can only offer services to the individual with an intellectual disability. We are not a behavioral health agency, and we're not an entitlement, and we can only support individuals within our appropriations. It is an agency that helps individuals with intellectual disabilities lead fulfilling lives. All programs are centered around the individual's needs, and we are responsible for planning, development, and administration of complete, comprehensive statewide services to people, which includes, as adults, residential and day services, again within our appropriations. DDS services are provided through our 3 Medicaid waivers. Those waivers are under DSS. They're the lead Medicaid agency, but we have operational oversight over those waivers. We have an employment and day waiver, we have an IFS waiver, and we have the comprehensive waiver. Again, waiver services are not an entitlement, and we are only funded within our appropriations. We have DDS may support an individual who's eligible, and it's for their entire life course. We have helpline supports, which has family support workers, transition advisors. We have clinical team consultants. Those are short-term services that can be put into a family home for a brief period of time to help out the family. We have family grants, which is incredible. We have 3.7 million, a little over, but that budget has not increased over the last 25 years. It's a cash subsidy that we provide to individuals and families to help defray the cost of disability-related expenses. That is really what families on our helpline tap into to get a little extra support. Oftentimes, that's for respite, summer camps, to help do a home modification, those types of things. Again, we'll get back to family grants later, but with the budget being as stagnant as it is, we're not reaching as many families as we used to. Residential supports, they're all listed there. Day supports, they're all listed there. Those are the services that are in our waiver that we offer. Again, I just repeated myself consistently that we're not an entitlement and we can only work within appropriations. So when I pulled this data, there were 6,001 person on our helpline. So that's a lot of people that our helpline has to work with. Again, when I pulled this, we had 86 emergencies, which means we had 86 individuals identified as needing emergency service residential services. So most of those 86, almost all of them would need residential placement. Some of them could need some in-home support, but at the time we had 86 emergencies. Our residential wait list, those are people that are identified of having an urgent need. We have 551 on our wait list that have no services. We have 292 that have some service, but would like more. And then for next fiscal year, we already know we're going to have 64 residential age outs. Those are people that come to us from DCF, voluntary care management, Carelon because their ABA is closing, subsidized adoptions, LEA placements that are going to end, and those internal to our Children's Services Division. Day age outs, again, come from that pot. And we have 350 grads. So we already know that we have that pot of people that we have to provide services to next fiscal year. And then we have what we call a planning list. And those are individuals where the individual or the family identified that they want something in the next 3 years. So we have 558 people that say in the next 3 to 5 years they want services, but currently aren't getting anything. And we have 88 people that are saying in 3 to 5 years, we would like more than what we currently have. Going back to family grants. So our family grant served almost 2,000 individuals in fiscal year 25, but we received requests 82% above what our budgeted allocation is. So we have a little over 3.7 million to spend, and we had over $6.7 million of request for services. To break down our ages, total population, 17,411. 79% of that is over school age, so 23 or older. 21% of those are school age. I wanted to break down the children's that we serve. Again, I say it's a small pocket because it really is a small pocket. Out of those kids on our helpline, 80%, 86% are with our helpline, not getting any services. 7% are with our Children's Services Program, and 6% are our age outs that we work with external agencies to plan for when those agencies are getting ready to close. And we like to plan for them well ahead of time. So some of these age outs are identified. They could be as young as 12 or 13 because we really like to partner with DCF and VCM around those individuals. So I wanted to take just a couple minutes to talk about our Children's Services Division. It's a centralized unit. And we want to address medical, physical, and behavioral needs for kids in Connecticut that can't get services anywhere else. We really try to work with other state agencies, their schools, hospitals, community providers, and families, and we really try to hook the families up with those services first. And we also have to do that because, again, we are a waivered program, so we are payer of last resort. We have to look at what insurance and the community can provide. We really want to strengthen families, and we want to identify where supports and services may be needed early so we can support a family. We can support the individual so their family is more stable, and we know avoid emergencies. So to be eligible, you have to be eligible for DDS, and you must be between the ages of 8 and 20. Our program is for people between 8 and 20, but you have to be found eligible prior to the age of 18. And you have to just demonstrate a need that is greater than what the community, state, or federal programs can provide. We will not consider somebody if they're asking for an out-of-home placement. Our most popular services are respite and individual home support. The reason we're finding those so popular is because someone can be getting ABA services and they don't offer respite. So the family is really engaged in ABA services and the individual is really engaged in ABA services. However, the family is not getting a break. So respite is very popular. The reason someone's not eligible for us is because they're not receiving a consistent education. We want to make sure the family and the school district is working to ensure the individual is getting a consistent education. If somebody's not living at home, we can't provide in-home supports. They're not at home. If there's an open case with DCF, then we don't open them in children's services as DCF is providing those services. Same thing with juvenile justice. If the family is requesting out-of-home placement only, we do not open them. If they have an open case with voluntary care management, because they're providing the services, and sometimes families are only interested in grants. They're not looking for annualized services. All they want is those grants. And then so we don't open them. They don't need to be in our program because they're getting the services that they need through those family grants. With outside agencies, we work really hard with DCF, BCM, LEAs, and Carillon ABA. I just had a meeting this morning with DCF in one of the regions to talk about who they have that's also eligible for us so we can do planning. We also meet consistently with voluntary care management and Carillon to make sure we see who we have that are in both, who are eligible for both services so we can do really good planning. The LEA, we don't meet with them because there's too many of them, but we once we identify that the school has placed somebody outside of the family home, we then let the school know that they're eligible for us, and we go to those PPT meetings and make sure we're part of the IEP planning process. We usually assign a case manager to those cases around the age of 18. So we assign a case manager and we really start identifying a smooth transition plan between both agencies. Case management is responsible for identifying the person's needs, coming up with their plan of support, making sure that they access services, monitor progress, making sure they keep the files. Our case managers are responsible for our level of need assessment, individual plans, and if there's any additional assessments required by DDS, they make sure those get arranged. So, and in the end, the numbers that matter, just things that little tidbits of information I think people might find interesting. The average age of our individuals in our group homes is 51. So when those outside agencies say, hey, can you help us plan or place somebody, our group homes, that average age is 51. It's really hard to place an 18-year-old in a home where the average age is around 51. But that's the average age of our group homes right now. Again, I put Southbury on there because typically one person has a question about Southbury. The average age there right now is 75. There are a little over 3,000 individuals under the age of 22 on our helpline. We have 312 kids in our division right now. And our Carolyn ABA services wait list can be up to a year, which is one of the reasons our division actually gets referrals, because they need supports now before ABA can get into place. Some trends we're seeing is that children with ID have difficulties being accepted into behavioral health programs like voluntary care management, PRTFs, ICAPs, the SACs. There sometimes is confusion where someone will say, oh, they can't, it's an exclusionary criteria having ID. I think the folks over at DCF know, I call all the time and I'm like, oh, someone on the care line said this again. Is it, have you changed your criteria? We want to make sure that that is not one of the criteria that is being put in place. When we met with, when we heard the presentation from the SACs last time, I'm like, oh, this is great. We don't know about this. Let's have them present to us. I asked the question at our meeting, do you take people with ID? They said yes. But when we met with them separately, they said, well, we don't take anybody with an IQ lower than 70. You can call us if someone's in the high 60s, but they have to be able to do all their own ADLs and they have to be verbal. And that really is a stumbling block for people with intellectual disabilities. And that does not have to do with their behavioral health need. It has to do how you address it. I understand that. But it means that our kids don't have the same access to community services that kids without an intellectual disability have. And I just put this out there all the time, is that no individual has ever been hospitalized because they have ID. So we hear that a lot. Well, they're here, they're stuck in the hospital because they have ID. That is not true. People don't get hospitalized because they have ID. There's other things going on, typically behavioral health. So I just always have to put that out there because it's one of my pet peeves when I hear that statement. So that's DDS. In a nutshell, as quick as I could do it. I hope I was less than 15 minutes.
Thank you, Tammy. And just so everyone knows, we will be saving questions till the end because we do have a lot of presentations. So I'm going to pass the floor now to Lorna at OEC.
Thank you so very much, and good afternoon, everyone. We know that this is a team effort, so before we begin, want to recognize those within our OEC team who are here, and so thankful that our Deputy Commissioner, Deb Fliss, is here. Deb?
Good afternoon, everyone. Deb Fliss from the Office of Early Childhood. I'm responsible for the Bureau of Workforce and Program Supports, which is where our behavioral health initiatives sit, and happy to be here today to support Lorna and Nicole.
Thank you so very much, Deb. And with that, we are honored to have our teammate, special teammate here, Dr. Nicole Cassette, who is the Part C coordinator for the state of Connecticut, who will share more information about Birth to Three. Nicole, passing it over to you. And Nicole, if your lovely voice is speaking, it may be on mute, but certainly would rather hear your voice.
Well, thank you. I was on mute. Good afternoon, everyone. I thank you, Lorna, and thank you to everyone for allowing us to really provide some information about the Office of Early Childhood's Birth to Three program, which is a wonderful program that I will provide a very high-level overview of. Just to call out that there are some nuances within our system that I won't get into the details today. you can go to trainings around early intervention that are day-long trainings. So we are getting the 30,000-foot view in terms of birth to 3 this afternoon. So what is birth to 3 or early intervention? Birth to 3 is governed by Part C of the Individuals with Disabilities Education Act, or IDEA. We work very closely with many different state agencies, DSS, Connecticut State Department of Education, where our Part B partners are Part B of IDEA. And I know Brian and his colleagues will talk shortly, but we work also with DCF and local partners. We have a lot of community resources that we are working with. The intent of early intervention is to really support children 0 to 3 who have developmental delays or disabilities. And that does include behavioral health, social, emotional, and some of the work that would impact this group. In terms of Part C, or birth to 3 is what we call our early intervention program here in Connecticut. For eligible children, services are provided through something called an Individualized Family Service Plan, or their IFSP. That really is a document that is developed with the use of evaluations, assessments, data, information from the family, and team decisions. So it's a multidisciplinary approach to developing these IFSPs, which include professionals such as occupational therapists, physical therapists, speech and language pathologists, psychologists, teachers. We have a wide array of folks working in our field who are amazing and incredible people supporting families. And we really want to build the capacity of parents, so parents are an equal member of that team as well. Services for our program are free. So for eligible children who have an IFSP, there are no cost to receiving services, although we do bill Medicaid and commercial insurance to try to recoup some funds and be fiscally responsive in terms of supporting the system. On this slide, you'll also see just very quickly in terms of how someone might get into our program or move through our program is we have a central intake line, or a single point of entry, to take all of the referrals for our system. So anyone who has a developmental concern for a child can make that referral. Most often that is going to be parents. Then the system would move that child into an evaluation to determine eligibility. Once eligibility is determined for eligible children, there is an IFSP developed, services, and then children who are still in our program and approaching age 3, we do work on transition services. For ineligible children, we will connect families with local resources in those community centers. Sometimes that looks like connecting families to Help Me Grow for developmental monitoring, and always calling out that you can always re-refer if there still continues to be a developmental concern. In terms of our referrals, here is just how to make a referral to our system. So we do have a central intake line that is our single point of entry. Once a documentation of that referral comes into our system and we have the appropriate contact information for the family, the demographic information, most importantly, where that family lives, our single point of entry will connect that family with a program who supports that family's town. We have programs in all towns and areas of our state, and that local program is the one that is going to be responsible for the evaluation, assessment, and services for eligible children. We also have an online referral form, and that is both HIPAA and FERPA compliant, so pediatricians can enter data into that online referral form and submit those referrals as well. We're trying to make this as easy as possible for families. We know families have a lot going on in that 0 to 3 space, and to have concerns of development, we know that that takes an incredible amount of care. So we want to make sure that this process is seamless for families and making sure that they're connected to resources. For our eligibility, in our state, Connecticut is a narrow eligibility for the Part C program. And what does that mean? It really looks at moderate delays in 2 areas of development or more, or a significant developmental delay in 1 area. And we're assessing, a referral may come in for 1 developmental domain, but we are going to evaluate for all 5 areas of development. It's not just the one that comes in with the concern. So we are looking at the whole child, the whole family, and doing the assessments that are appropriate after those evals to collect more information. One other nuanced piece to Connecticut's early intervention system is that we do have a diagnosed medical condition list. We know that there are some conditions that have a high probability of developmental delay. That could look like lead exposure, it could look like NAS, FAS, neonatal abstinence syndrome. Those diagnosed conditions, regardless of the child demonstrating a developmental delay, would equate to an automatic eligibility into our system, because we know that early intervention does speak volumes and really changes the trajectory. There are some at-risk diagnostics that we do take into account as well as part of that auto-eligible, and that does look at prematurity and low birth weight. And these are all consulted with a pediatrician. So we're not just in silos making these decisions, but we're collaborating with the medical community and current evidence-based research to make these determinations. And that QR code would bring you right to that diagnosed medical condition list. We also have one other piece to our eligibility, and that is clinical opinion. So for children who may be right on the cusp, but perhaps they're a month away, or we know that there is some concern still, our clinicians can use their clinical opinion to determine that eligibility and then continue to move that child through services. It's not often used. Most often we are determining eligibility based off of developmental delay, but clinical opinion is used at times. And a child can be re-referred at any time. So if they're ineligible, we will connect to resources and continue to support that family. However, anyone can re-refer at any time. And most often we do get a lot of re-referrals into our system. And some of that information that we're providing with families, if they are determined ineligible, is information about Help Me Grow, Sparkler, community-based resources, and of course CPAC, the Connecticut Parent Advocacy Center. They are such an amazing resource for families and support families in that birth to 3 space, but also beyond birth to 3. And they help families through transition out of our system and into perhaps preschool special education and beyond in their educational journey. So CPAC, I cannot speak highly enough of their partnership and how they really help connect families to other resources as well. I also just wanted to show you all some data in terms of the number of children who are being evaluated and thus determined eligible for our system. We have seen an incredible growth in the birth to 3 system. There have been more referrals, which is not outlined here. However, there are an increase in our referrals and thus an increase in the evaluations and those determined eligible. So really seeing much more of a need for birth to 3 services throughout our state. We have on average children who are determined eligible will stay in our program from 11 to 12 months. So we have such a small window in helping and supporting that family. Most of that is due to when we're getting the referrals. We're typically getting children that are probably around 24 months of age. So we're really starting to see that closing in on that age 3. We're working on our 0 to 1 population, trying to increase some of the capacity there, because we know that there's some misses that we're really trying to address in terms of auto eligibility and referrals, and making sure we're receiving those referrals early and being able to support the families. And why is that so important? It really does look at what the intent of our program is. Now, this is my favorite piece of research. I might be a little bit of a geek here. However, when we think about supporting families and empowering families and really helping the parent understand development and helping their child develop and learn, in terms of the research, we know that children learn through an incredible amount of practice. So there was a bit of research completed in 2003. I know it's a little bit dated. However, Karen Adolph and her colleagues looked at the number of steps a child walks in a day and how many steps are taken per hour and how many steps does that equate to one day in order to master walking. So what does that look like? On average, toddlers are walking about 6 hours daily to master walking. That equates to 500 to 1,500 steps per hour, 9,000 steps per day, which is 29 football fields, which is absolutely incredible to think about how much practice goes into walking. If there is a motor concern and we are helping that family help their toddler walk and master walking, 1 hour of an early intervention visit is not going to see 29 football fields. The parent, however, might be chasing their toddler through those 29 football fields. So if we're able to embed our practices, help parents' confidence and competence, and really help their child develop and learn, which is our mission here in Connecticut, that child will master walking at a much higher rate than just early intervention alone. So really the capacity of parents is so very important, and that's going to follow that child and that family throughout their life. So often I hear from families who have had birth to three in their life 20, 30 years ago, and they still talk about how even on the adult side of things, early intervention helped them advocate for their child and help their child develop and learn. And the other piece in terms of that transition, I just want to display on my last slide here some exit and transition data. So most often we are seeing children exit at age 3. Again, that's largely due to our referrals and when we're receiving those referrals, but often we do see children stay in transition. Many are eligible for Part B preschool special education. Some are ineligible, and for those who are ineligible, there's developmental monitoring and connection to resources there. And then for those that leave before age 3, most often it's a completion of the IFSP goals. So IFSPs have goals that the families work on, and once those are achieved, there are often new goals set up, but at times families say, their child's doing great, they're no longer needing services, and they will exit prior to age 3. So anecdotally, those are some of those reasons for those exits. But happy to remain here and take questions at the end. I know that we're holding them, but I know that there are some really incredible presentations next. So I will end there and say thank you all very much for your time and for supporting the Birth to Three system.
Thank you, Nicole. So I will now pass it to Brian at CSD.
Thanks, Emily. Good afternoon, everyone. Brian Klimkowitz, Special Education Division Director for the State Department of Education. Also on the call with us today is our Deputy Commissioner, Cynthia Sone Moyano. And I will be sharing our slides with you here in just a moment. Similar to the previous presentations, we'll be providing a very high-level overview. Try to keep it brief here in our presentation, but happy to answer questions at the end. Also, with a specific focus on students with autism as their primary disability category and/or intellectual disability. Emily, are you seeing my screen?
Yes.
Okay, great. I'll just go into slideshow here. Thanks for your patience, folks. So wanted to mention the importance of our State Board of Education. So at the CSDE, we are the state educational agency with that responsibilities related to the education of our youth across the state. Our board has a strategic plan in these 4 areas around equitable access, safe and healthy learning environments, elevated curriculum, and then that path to career and employment post-secondary. And so as an agency, we work within these strategic areas across a variety of departments at the State Department. You can see this is a nice logo here centering the students and all the work that we engage in. And specifically with the Bureau of Special Education, we are charged both federally and with state statute to ensure that there are general supervision systems in place to improve student outcomes. Unlike some of our sister agencies, we do not provide direct services to students or coordinate direct services for students who are eligible for special education. That is the responsibility at the local level with the planning and placement teams. Just a reference point for you for our organizational structure under the leadership of Commissioner Russell Tucker. I mentioned the Deputy Commissioner who we report to in the Bureau of Special Education. There are 2 Deputy Commissioners at the State Department, and you can see the various areas that they oversee within their leadership. It's important to point out that although there are separate kind of structures within our organization, we work very closely with our colleagues in across other departments, and students with special education needs are general education students first. So we coordinate with each and every department and division within our organization. I thought it might be helpful to show a little bit of a breakdown of our Special Education Bureau. We do have 3 units within the Bureau and a Bureau Chief that works alongside in managing and supervising our work. We are responsible for all of the dispute resolution systems that take place in our state. Most often access our complaint system, mediation, due process, and we also have a process called resolution sessions. That middle column there is our charge around general supervision, which I have a slide to get into a little bit more depth on. And then we also are a fiscal fiduciary for our LEAs in a pass-through grant. Nicole mentioned earlier the IDEA Part C. Our Bureau is responsible for IDEA Part B. And so we do receive funding on an annual basis for a 2-year grant for our LEAs. And we have an application process that we oversee and also monitoring to ensure that those funds are directly impacting students who are eligible for services. When we talk about general supervision, this is a nice graphic I like to point to where the federal government expects the state education agency to have at least these 8 components within our general supervision system. You can see the effective dispute resolution is one of them, and fiscal management, which I mentioned earlier. Again, for the purposes for today, we'll be speaking a little bit about our responsibilities related to students with primary disability categories of autism, intellectual disability, and also developmental delay, while highlighting some of the recent legislative changes. And as always, our ultimate goal is improved outcomes for students with disabilities within the Bureau of Special Education. This is a wonderful slide that I won't speak to or talk through all of these data, but just a nice reference point that we recently shared with our State Board of Education around current the makeup of the variety of students that are supported through our districts, number of schools, FTE staff across the state. Highlighting for today's purposes, students with disabilities with 94,000 plus students. Those are our K-12 prevalence data. You can see the increase over time. This is a great visual to show over the course of the year the increased prevalence rates. We often receive questions about what are the causes or reasons or hypotheses for the increased rates. And there are a number of factors that are resulting in this increase. Connecticut is not alone. This is also happening across the country for the increased prevalence rates. While this is happening, we also have a decrease in our all student K-12 counts, which naturally would increase the percentage, but that decrease in the denominator, if you will, is not the only reason for the increase in our prevalence rates. But you can see the dichotomy there of our students who are eligible for special education rising while our overall student count declines. This visual will show the various disability categories that we report to the federal government on. There are 13 federal primary disability categories. In Connecticut, we have 15. And when we report to OSEP, we combine some of the disability categories. For our purpose today, also wanted to highlight eligibility for students with autism. We've seen in the last year alone a 10.5% increase, and over the last 10 years, almost 100% increase in our prevalence rates for autism. And you can see similarly students who are identified with a primary disability category of intellectual disability, a 26.4 increase over that same time frame. And I included some of our other primary disability categories as well for a reference point for you all. When we speak about eligibility and primary disability categories, it's important to understand that those are educational based on IDEA criteria for eligibility. So planning and placement teams are making these determinations. Students are not required to have a medical diagnosis to be eligible for special education. The team needs to identify a disability that adversely impacts their education and thus requires specially designed instruction. And so part of what our office does is support those local teams in making accurate identifications for our student population. I did want to share some information, recent legislation that was passed related to one of our primary disabilities, which is developmental delay. Prior to the passing of this legislation, the ages that a planning and placement team could utilize this disability category were from ages 3 through 5, meaning once a student turned 6 within their educational program, the student would either have to be exited for special education or meet criteria for one of the other 12 federal or 13 categories in our state at that point in time. With the passage of this legislation, that expanded that age through 8. And now a student may have that as a primary disability category up until their 9th birthday. This does not preclude planning and placement teams from changing the disability category earlier or identifying a student with a different primary disability prior to that age. Won't go through this in depth here for you, but wanted to include the federal definition for developmental delay as it relates to special education eligibility and the guidance that we've provided to school districts. I've included a link for you as well. We have amazing coordination and collaboration with our partner agencies. Nicole mentioned earlier the work that we do as students and families are transitioning from Part C to Part B. They are different laws in place and different rules and regulations. So this can be a very confusing time for families. So throughout the year, our two departments run a series of training and information sessions for families and educators. There are requirements in place for school districts to be able to make determinations in a timely manner when we receive referrals from our partners at the Office of Early Childhood and students coming from the Birth to 3 system. We have a statewide system in place that has really improved that coordination called Connecticut Special Education Data System. And we track and monitor and report federally for students who are evaluated and eligible. They must have an IEP in place by the child's 3rd birthday. The transition is really critical. Nicole touched on a variety of those reasons earlier. So here, just to highlight a few around the continuity, to ensure as seamless as possible a transition from one sort of regulated set of laws to another. And of course, establishing that foundation of partnership, trust, and communication with school districts at that early age for our students and families. I included a table here for our points of contact across all of the variety of agencies that we work with. On the other end of the spectrum, when our students are aging out, whether that be for achieving their regular high school diploma or for students who reach maximum age of eligibility, the secondary transition responsibilities for our LEAs begin at age 14. They can begin earlier for students with more intensive needs, and we coordinate, our local school districts coordinate with adult agencies for students who may be eligible for support either with employment, post-secondary education, or independent living. So including those points of contact, we have a variety of interagency councils and committees that we coordinate our responsibilities around. And finally, just wanted to mention and highlight the interagency collaboration related to mental and behavioral health areas. These are just a few of the recent or upcoming collaborative trainings and support that we provide in collaboration with DCF, DMIS, and our partners at the Department of Public Health and Office of Child Advocate. We report on a regular basis these activities and updates through a variety of communication channels. So again, appreciate the opportunity to share this information and the CSDE's role in supporting our families and educators to improve outcomes for students.
Thank you, Brian. I will now pass it to Susan and Nathaniel, I believe, from DSS.
Hi, thank you. Let's see, I'm going to share. Can you see my screen? Oops, whoops.
It's loading.
I'm
There we go.
going to stop sharing that screen. I'm sharing the wrong screen, I think.
I see your slides.
You do?
Yes.
Okay. Sorry about that. So I'm Susan Stang. I'm from Department of Social Services. I'm the manager of the autism program, and I have Nate Calixto here with me, who is our autism support and resource specialist. So we're going to just give an overview of the autism waiver program. DSS operates a home and community-based services lifetime waiver for individuals with autism who do not have an intellectual disability. To be eligible for the autism waiver, which as a waiver and as Tammy mentioned, is not an entitlement. A primary diagnosis of autism spectrum disorder is a requirement. Residency in the state of Connecticut. Diagnosis prior to age 22 and expected to continue indefinitely. Cognitive and adaptive functioning level above the level of intellectual disability. Substantial limitations in 2 or more of the following major life activities: self-care, understanding and use of language, learning, mobility, self-direction, or capacity for independent living. Individuals enrolled in the autism waiver have their needs assessment done annually by case managers, and they're assisted by case managers to create a plan of care with identified services to meet their unique needs. There's a cap of $50,000 annually for the plan services. And the services that the waiver provides are behavioral services, job coaching, community mentor, life skills coach, social skills groups, respite that can be in home or out of home, assistive technology, interpreter, specialized driving assessments, personal emergency response systems, individual goods and services, non-medical transportation, and nutrition. Potential coordination with other state services. We coordinate with the Department of Developmental Services. That department does the determinations for people to be eligible for the autism waiver. There's also a need at times for transition to DDS for somebody that's currently on the autism waiver services. Because the autism waiver, which is designed for those that do not have an intellectual disability, is open to individuals age 3+. Sometimes individuals, due to being eligible at a younger age, are later determined to have an intellectual disability. So they can get redetermined. When this occurs, DSS coordinates with DDS to transition those individuals to appropriate DDS services. DSS also coordinates with the Department of Children and Families through specific reserved capacity slots. There are 5 annually, and they're available to individuals in DCF who are eligible for the autism waiver. And we work with DCF to identify those individuals throughout the year who may benefit from waiver services and who also meet the eligibility criteria. Sorry. And then possible gaps or barriers to service. A gap or barrier to services on the autism waiver may occur due to the steadily growing wait list, which every month it grows, as somebody else mentioned also. More and more people are getting diagnosed. So there's a barrier to services because the steadily growing wait list and limitations on the availability of administrative staff, providers, or case managers. There's a provider shortage, so oftentimes we bring people onto the waiver and then it's difficult to find providers. So that's definitely been a challenge for us. And I probably have the quickest presentation of anybody, but for more information, you can visit ct.gov DSS and find lots of information. Nate has done a great job of filling that area on our webpage with a ton of information. Or you can contact myself or Nate.
Thank you.
That's
I
it.
will now pass the floor to Stephanie and Frank at DCF.
Thank you so much. Hopefully I can share this. Are folks able to see the screen?
Yes.
Perfect. Thank you so much. My name is Stephanie Bozak. I'm with the Department of Children and Families, and I actually sit in the Behavioral Health Administration Division, and I'll talk a little bit about the differences about that. But essentially, I wanted to start, and I'll be talking about sort of the two sort of areas where this work sits. DCF's statutory mandates and strategic goals. We obviously have involvement in child protection, which is where we are tasked with really protecting children from abuse and neglect. We are also tasked with children's mental health and substance use treatment, as well as prevention and early intervention. So as I mentioned, I'm going to be talking about that sort of in 2 separate parts, the child protection and then as well as the children's mental health and prevention. As it relates to child protection, DCF serves as the statutory child protection agency. And so as such, we respond to all reported incidents of child maltreatment statewide. And this is through our care line, which receives over 100,000 calls each year, resulting in investigations, family services, and case closure when there's no statutory concerns that are present. And so Careline would be the first front door related to those child protective issues. Families can receive in-home, out-of-home family services based on an assessment of needs, or the case can be closed, like I mentioned, if there are no statutory concerns. In addition, DCF does offer services post-majority, which essentially means that we would support transitional age youth up through the age of 24, based on commissioner waiver if DCF was the statutory parent and guardian prior to turning 18. I do also want to address a couple of things that kind of came up in previous presentations, just related to some of the collaboration. So we heard DDS presenting earlier about some of the collaborative work that is being done, and that's through our transitional supports and services, the Interagency Navigation Division. So this is where they would be really focused on those individuals who are involved with DCF. And what I mean by involved is not necessarily investigations, but in those in-home or out-of-home family services. So there's been a statutory sort of concern that meets the level of DCF continued involvement. In those cases, DCF and DDS works collaboratively. We also heard from Susan just previously about the work that's collaboratively done between DCF and DSS, and we'll hear later from Demas about the collaboration that happens between DCF and the Department of Mental Health and Addiction Services, and this is related to those transitional age youth. And again, that is when those involved cases are in our in-home or out-of-home family services. When it comes to Careline, however, and I think this was kind of mentioned, if there is no statutory concern, they don't meet that criteria. And so in those reports, I think it's important to mention that, we've heard a little bit about eligibility. And so DCF is bound by similar, where if there are no statutory concerns that are present, that case would move towards closure. And in those closure, they may mention that DDS is involved or somebody else is involved, just as ensuring that, that we have full information when we're assessing for any of those needs or concerns that may be present. In addition, we also heard from the Office of Early Childhood, and so there is some collaboration there that occurs, not necessarily with those transitional age of our older youth, but with those younger youth. There's also work that is done related to making sure that we are screening and sending referrals to birth to 3 services if and when appropriate. There's also a lot of collaboration that's done between the Department of Correction as well as the Judicial Branch Court Support Services Division. Next, I'll move over to our behavioral health and community services. And again, sort of splitting this presentation up into 2 parts, because I think one of the things that I really want to ensure folks understand is that DCF does not provide direct services for behavioral health outside of the 2 PRTFs. So DCF oversees behavioral health services for all children statewide, but this is done through a partnership model with our providers, schools, and community agencies that we contract with, that we work together with. And outside of that, DCF does operate the 2 psychiatric residential treatment facilities, which we heard about the PRTFs in last month's meeting. Families can access all of the services through school referrals, pediatricians, community partners, and through our crisis continuum. So what I mean by that is if somebody is calling mobile crisis, they can access the continuum of services Or they can do that through self-referral. If I know that my child meets the criteria, or I'm thinking, you know what, I really need to have somebody referred to a specific type of program. There are programs that they can self-refer, but we also rely on community partners, like I mentioned before, for those referrals. Key service categories, I've mentioned a few of these already, but they include our outpatient psychiatric clinics, our intensive in-home psychiatric services. A lot of people refer to this as our alphabet soup, right? Because of all of the various initials and acronyms that are used. But that includes multisystemic therapy, MST, functional family therapy, which is FFT, and a variety of others. We also have our crisis services, such as mobile crisis. We also have the UCCs, which we've heard of a lot here, and 988 in partnership with the Department of Mental Health and Addiction Services. There's also care coordination services, extended day treatment, and therapeutic group homes. And one thing to note about all of these service categories is that each of the providers really engage with youth and family to ensure that what they are offering is going to be responsive and appropriate to the individual family's needs. We heard a little bit about eligibility criteria and things like that. And so all of our providers would be working very closely with the referred person to determine if it's an appropriate referral. I also wanted to highlight the Connecting to Care website. Again, as I mentioned, a lot of these services are accessible through the community, and so this website is a really great resource that was developed as part of our system of care through support from a grant that we received. And this is where you can really find a lot of information about what is available to families in the community. So you can see here there's a number of different sort of areas within the website. The assisted intervention matching tool is where families can go, or providers, and there's like a decision-making kind of question that asks a lot about what it is you're looking for. If you're a parent, a provider, if you're looking for support for yourself, or if you're looking for support for a child. And as you go through the questions, it narrows it down and then gives you a list of what seems to be the most appropriate based on how you answered those questions. Understanding supports and services is a great tool for where you can really hear about what the supports and services are. It gives descriptions about them. It will talk about what is related to your area. So if I know about, I want to find out specifically about an FFT service, functional family therapy, it will give me exactly what the criteria is, and then it'll also give me an idea of where I can find that. Learning about care coordination, what they can offer, and then find supports and services. This is an area, if you really don't know where to start, it will send you like a map or a region, and you can kind of look through the list of providers in that area. And then there's also a section about what's your mental health plan, encouraging people to develop their own mental health plans. And we would not be able to do this without partnership and collaboration with our community partners, like I mentioned. And Carillon has been mentioned a couple of times, and I want to just highlight two programs that they have. So voluntary behavioral health and community pathways. These are DCF funded programs. However, they are administered by Carillon, and they are available for families seeking help without child protection involvement. So again, sort of splitting out that difference of when they are DCF involved and when they are in the community without those child protective issues. So anybody can access the voluntary behavioral health or community pathways. They would, again, like I mentioned before, sort of assess and determine if what they can offer is appropriate. And DCF partners with others to ensure that there's coordinated access at the local level. So again, this is done in a coordinated, localized way. And these are done through the community collaboratives, and you can also learn more about that on that website that I was talking about earlier in the previous slide. Other key partners, we've mentioned them all before, but of course, DEMIS, which you'll be hearing from next, the Department of Developmental Services, the Department of Education, as well as OEC and many others. So there's a lot of collaboration and coordination that happens in partnerships to really ensure that our continuum of services is responsive to the needs of our communities. And then there's just some contact information.
Thank you so much, Stephanie. I'm now going to give the floor to Amy at TMIS.
Thank you, Emily. Good afternoon, everyone, and I will try to share my screen. Am I sharing?
No, I do have it up if that's easier.
Oh, let me try one more time.
There we go. It's loading.
Is it working now?
Yes.
Okay, excellent. Okay, so my name is Amy Maracino, and I'm the Section Chief for Young Adult Services with the Department of Mental Health and Addiction Services. And I'll be sharing some information about our Young Adult Services program this afternoon. So Young Adult Services, which we commonly refer to as YAS, with DEMIS. I'll start by talking about some of our partnerships. So Young Adult Services, we were established to support individuals between the ages of 18 and 25 in successfully transitioning from DCF to the adult behavioral health system and to be able to acquire the necessary skills for adulthood. So DEMIS originally received funding from the legislature for our Young Adult Services program back in 1997, at which time there was a recognition that there was a need for age and developmentally appropriate services for young adults who are aging out of the DCF system of care and ending up in either psychiatric hospitals or correctional facilities or homeless shelters, which resulted in the development of these specialized services for young adults and the great partnership that we have with DCF around transitioning those individuals into our services. And the young adults that we serve are between the ages of 18 to 25, living with complex psychiatric presentations. Many of them have significant trauma histories and also may have histories of problem sexual behaviors, legal involvement, substance use disorders, along with significant psychiatric presentations, as well as other high-risk behaviors. And so we currently have memorandums of agreement with DCF, Careline, and CSSD to facilitate early engagement, referral, assessment, and transition planning for youth and young adults. And we begin that process as early as age 16 so that we can effectively plan for the transition of services that they receive from us at as early as age 18. And if a youth has IDD and is eligible for services through the Department of Developmental Services, then our Young Adult Services program will often collaborate with DDS to plan for clinical services that the youth may need as they prepare to transition to services in the adult system. So our eligibility criteria, the individual must be 18 years of age and older. They also must have a documented major mental health diagnosis. And I just include some examples because sometimes people have questions about what constitutes a major mental health diagnosis. So these are just a few examples, such as post-traumatic stress disorders, psychotic spectrum disorders, bipolar disorder with psychotic features, major depressive disorder recurrent, for example. And the young person must also be willing to participate voluntarily in our services. Our services are voluntary. They must be referred to DDS first if their IQ is below 70 to make sure that if they're eligible for DDS, that they do have that opportunity to receive services from that agency. And they may be diagnosed with an autism spectrum disorder, but they must also have an existing major mental health diagnosis as well. And then some of the service components of Young Adult Services, we have a Young Adult Services funded program in every one of our DEMIS local mental health authorities, both state operated and private nonprofit agencies throughout Connecticut. So we have 13 DEMIS local mental health authorities, and we actually have 18 sites because some of those local mental health authorities have multiple sites. If an individual is not involved with DCF, Careline, or CSSD, they can also still access Young Adult Services by requesting an intake appointment at the local mental health authority in the area where they reside to be screened for services as they approach their 18th birthday. And Young Adult Services contracts with a number of private nonprofit agencies to provide specialized services, including specialized residential programs. And for example, we serve specialty cohorts of young adults, such as individuals with diagnoses on the autism spectrum that also have a major mental health diagnosis. We also have a 17-bed young adult services inpatient unit on the grounds of Connecticut Valley Hospital. And this slide just has a list of the different specialized, just the services that we offer in our statewide young adult services programs. So we're focused on providing specialized trauma-informed care for individuals who meet our criteria. We focus a lot on skill building, recovery, and our programs are really designed to provide really intensive resources, particularly upfront, to really support individuals in gaining the skills that they need to successfully transition to adulthood. So we offer the range of services here, including psychiatry, individual therapy, case management, a variety of clinical services to meet specialized needs. We have young people with complex medical challenges at times, so we have nursing services for our young folks, group psychotherapy, and a significant focus on trauma services. We train all of our programs in the ARC model, the Attachment Regulation Competency Framework. And then we also offer specialty trauma-informed services that really are tailored to meet the needs of that individual young adult. We offer peer mentoring. So we have individuals with lived experience to support our young adults, crisis services, lots of focus on life skills development, rehab services, money management, teaching them the skills that they need to successfully transition to adulthood. We have consultation services that support young adults who may benefit from something like a positive behavioral support plan to be able to support them in what they need in the community. So they might be living, if they're able to live in their own apartment and they need some ancillary services, or if they're in a residential program and need additional specialized services, we can offer that to our young adults. We offer assessment services. There's a heavy focus on employment and vocational services to really prepare young people to be able to have the skills to obtain a job and maintain a job, and also to continue to pursue any post-secondary education goals, and all of the things associated with helping to get their driver's licenses, to get to work, etc. Residential housing support. So regardless of where they're living, we provide supports and services in those levels of care, whether it's a residential program or their own apartment, to support them. We also have a program to support young parents. So when a person becomes pregnant or we learn that they're pregnant, we offer them the perinatal support program. It's offered by an agency called Birth Support Education and Beyond. They're assigned a perinatal support specialist, and they can receive, at the time of their pregnancy, can receive services from this team to help them to make sure that they're getting to their prenatal care appointments, preparing them to have the baby, going with them to when they're brought to the hospital for delivery. They're with them through the whole process, and they offer services to that individual once they're in their home after they have the baby, and they partner with the Young Adult Services clinical team to really try to provide as many supports and resources that the young person needs to be able to successfully parent their child. And then we also offer substance use services. We have an increasingly high number of young adults who, in addition to major mental health diagnoses, also have substance use diagnoses, and we provide age and developmentally appropriate training to staff to work with individuals with substance use disorders as needed. So I will stop sharing it. And I'm sorry, I do have one last slide if I can try to put it back up. The last page has just just a link to our DEMIS website. Let's see, is it back up?
Not yet.
Oh, it's not.
I can quickly share it. I have it.
Thank you so much. I appreciate it. So yeah, I just wanted to share this with folks because it has just a link to our DEMIS website, just so you can see more information about our program, as well as more broadly services offered by DEMIS.
Thank you.
Thank you.
So for our last presentation now, I am going to give the floor to Miriam at the Department of Public Health.
Good afternoon, everyone. Thanks for sticking with us to see DPH's presentation. I'm just giving one moment to put this slideshow. Okay, can everyone see the slides?
Yes.
Great. Okay. So we'll start by talking a little bit about our Title V Maternal Child Health and Block Grant, and then get more into our regulatory activities. I think what sets DPH apart from several of the other agencies that you all have heard today is that we are not necessarily a direct care service provider, and outside of, but we do a lot of funding and regulatory work with the with this population. So on the maternal child and health block grant, we support a few different categories, and there's a second slide with more information, but the three main buckets are adolescent and child health, children and youth with special health care needs, and then cross-cutting systems infrastructure. Under child and adolescent health, we do a lot of work with school-based health clinics, specifically in 4 service areas, which is the Hartford Board of Education, City of New Haven, Optimus Healthcare, and Children and Family Agency of Southeastern Connecticut. And it's providing medical, dental, behavioral health, and prevention programs at the school-based health clinics, which can include prevention programs, physicals, immunizations, behavioral health screenings, and therapy. Under this bucket of work, we also coordinate developmental screening through early childhood systems. And this is a contract with United Way of Connecticut, working mainly with 211 to provide free developmental screenings and monitoring for children from ages birth to 5, including ages and stages questionnaires. So it helps parents track developmental milestones. And there's also an app that families can use to track activities and links families to other services. Under the children and youth with special health care needs, there are kind of 5 contracted services that we work with to provide care coordination for this population and their families for medical, developmental, and social supports. We work with Connecticut Children's on this, United Community and Family Services, St. Mary's Hospital, Stamford Hospital, and Family Centered Services of Connecticut. The next bucket is cross-cutting systems infrastructure, where we have where we support statewide service navigation, where we maintain a statewide centralized information referral system, connecting families to health and social services, care coordination, and is a key access point for our Title V priority populations. The one thing I just want to also highlight within these 3 buckets is that the maternal and child health block grant is not, you know, by all intents and purposes, a massive grant. And so none of these programs are necessarily fully funded, but more supplemented with this funding. So I just want to make sure that's also clear. Next we have, and I'm sorry about the Teams notifications. Next, just give me 1 second. I'll just share a different screen. Sorry. Okay, this should be better. Sorry, it's legislative session, so we're all making through. Okay. Okay, so our regulatory activities, we are the state survey agency for PRTFs. So we have entered into an agreement with Department of Social Services that basically allow us to apply federal standards to the facilities. So when these facilities are licensed, we would go in and do the regulatory activities for these facilities. We also act on behalf of DSS to review any serious occurrence and conduct audits. And PRTFs are required to have an on-ground school, which is under the purview of STE. And then we currently have 2, and we act on behalf of DSS to review any serious occurrence or conduct audits. Sorry, I said that. And then DPH licenses 2 PRTFs in Connecticut, Solent North and Solent South. We also are the survey agency for intensive outpatient programs. We conduct in-person surveys of the facilities and services based on their licensure category. It could be a psychiatric outpatient clinic or hospital where other kind of hospital where these services are provided. So that's actually all that we have on the DPH front. Again, we are a relatively small player in this field, but happy to work with populations and other people providing similar care levels. So thank you.
Thank you, Miriam. And before we go into question and answer segment, I did want to give the floor to Adriana Ramirez, who is representing the Connecticut Family Support Network, but she is also a member of the TCB's Community Voices work group.
Good afternoon, Emily. Good afternoon, everyone. I am here just to speak for a minute or two these wonderful presentations. And as part of the Community Voice Work Group, we were working, of course, with the parents and caregivers of the community that we're speaking about today. And as we hear presentations today, such great information, and I'm glad we're here to help understand what everyone is doing and how we can work together to support the community. But for the parents and caregivers, it is complex to navigate the system, and even ourselves as professionals, understanding what different agencies do, different organizations do, and how, depending on the diagnosis or what's happening, as Tammy said, someone's in the emergency room or in the hospital, but it's not because they have ID, but because that's their main label, all of a sudden that is what's looked at versus really looking at the whole person and co-occurrences. Our parents and caregivers, imagine yourself, they're trying to go through, imagine the presentations that you had just now listened to, and imagine all those acronyms. Now, you don't have to learn them right now, you just have to learn your own agency. But if you're a parent and caregiver, you have to learn all those acronyms plus more. You have medical, you have everything. So our parents are overwhelmed and they're expected to try to navigate the system that most of us, when we are paid as professionals, are still trying to figure out how to navigate, but parents are held to follow their families, raise their families, take care of themselves, take care of their families, navigate, advocate. There's so much put on parents that I'm glad for these conversations because we are coming together to support and figure out how can we work together to better support families. And that's why organizations like ourselves at Connecticut Family Support Network, that's what our main focus is really supporting the parents and caregivers, supporting them in navigating as much as possible through systems, through organizations, through acronyms, through different cliffs as parents speak about. And I know we talked about it in this presentation. You have the entitlement versus the appropriations, and that's a huge cliff of that transition. So I just wanted to share that our families have a lot of barriers, and it's not for trying. It's not for lack of education. We have family members, parents with PhDs, master's degrees that are struggling with the processes and the information, let alone our community of underserved families that are trying to struggle as well. So how can we come together and create tools or systems to be able to better support our families? And I'm glad that organizations such as ourselves and others in Connecticut exist for that support. So I welcome for all of us to really work together, look at our strengths and focus on that to really wrap around these families because they are doing their best. But every day it's a struggle. So thank you.
Thank you, Adriana. So I will now open the floor to any questions or comments anyone has for any of the presenters. I know it was a lot of information. And if there are questions following this meeting, you can send them to me and I can provide them to the agency who would be able to answer. But yes, Christina.
Good afternoon, everyone, and thank you for the presentations. It's been very helpful to sort of look across the system at the various pieces, various pieces of the system that are handled by different agencies. I think one of the things that is really important for this group to be thinking about are the gaps, right? So we heard about each agency, who they serve, what kinds of services they offer. But in that kind of presentation, sometimes it's hard to understand, like, where are the gaps? And so I think there are a couple of things that I'd like to highlight. One is there was a comment about ABA services, applied behavioral analysis, which is, sort of the go-to treatment for children on the autism spectrum. There's a 1-year wait list for those services. There are no residential placements for children through DDS. So if you've got intellectual disability and co-occurring other disabilities, where do you go if you need a residential placement? It's not DDS. It's not available under the autism waiver. If you are not abusing or neglecting your child, it's not available under the DCF child welfare umbrella. And so the only other option is voluntary care management through CareLon under the DCF mental health umbrella. But you can only access that if the primary reason for the need for those services is a mental health diagnosis. And so very often we see children with those co-occurring disabilities, and there's a bit of a tension between agencies about what the primary disability is and what the reason for the need for services is. And what happens at times is nobody nobody considers themselves to be the primary agency that's responsible. And so the family really has very few options. And that's true with regard to in-home services as well. Again, if the primary driver is the combination of intellectual disability and autism and behavioral health needs, there's going to be that question of, well, what's the primary diagnosis? What's the need for services? And if you go to voluntary care management, they say, well, autism's the primary reason that you need these services. You may not get those in-home services. So it's just a very challenging for families, not just figuring out which door to go to, but sometimes there isn't a right door. And I think that's really something that we need to work on as a state. First, that families should be able to go to one door and get all the information they need and have someone else who's got expertise figure out where are those services that the family needs available. And second, we need to ensure that we really do have a continuum of services so that families can get what they need when they need it. So thank you.
Thank you, Christina. Are there any other questions or comments?
Yeah, hi, this is Mickey. Hi. I agree 100% with what Christina just said. And that, this is very helpful because I think, it really, I think each state agency and their description of their contribution to our systems of care. But it just is kind of mind blowing that it's so, the spectrum is so broad and trying to put ourselves in the place of, in the framework families trying to navigate is just just completely overwhelming. I also believe that we really do need to focus on exactly what Christina said. Where are the gaps in this services, right? We heard very specifically around we're all very worried about the population of kids with IDD. And yet we heard a lot of we don't do. Right, from our developmental services agency, and that's not Tammy's fault, right? That's just kind of the way we have developed our system. And so I really hope that what we can do is take all this information and craft a plan that moves us forward, right, in terms of how we, whether it's across all those agencies or maybe coordinating through just a few agencies to ensure that we are not so exclusive and we're so many families falling through the gaps. So
Thank you.
did the presentations.
Emily, there was a question in the chat. I don't know if it was answered. It's what is the expectation for families aging out of school and getting a case manager? And I think it was during Tammy's presentation.
Thank you.
The expectation. If they are a grad, typically they try to assign a case manager 6 months before they age out. Again, we have a case manager shortage, so not everybody gets it. To get a case manager, somebody does have to have Medicaid so they can be waivered. Typically around 6 months before they graduate. If they're an age out, it's a little bit different because there's more planning because we have to do residential and day planning at the same exact time. That's why in my presentation, if you look at the slides, there's one number for age outs and there's one number for grads. So that's the difference right there.
Thank you. Lorna.
Yes, good afternoon. Again, not a question, but more so a follow-up. Adriana, very much appreciate your advocacy with Parent Voice and uplifting Parent Voice, and the timeliness of you sharing that aligns well with an event that OEC is having this Saturday that I would like to share with you all, and I'll put the flyer in the chat as well. It is a part of our Parent Cabinet WELL subcommittee. WELL stands for Wellness, Engagement, Lasting Leadership. And the purpose for this event is a community conversation, is to do just that, to be able to engage with parents and families, to hear what their thoughts are, to hear what's on their mind as it pertains to the needs of their family. We held our first one in February in Danbury, and we're hosting our second one again on Saturday in Stamford. And our goal is to rotate throughout Connecticut to cover all of the 6 regions. So again, I will put the flyer in the chat. If you're not able to make the one in Stamford, no worries. Again, we're making our way throughout Connecticut. But the main piece is to ensure that we are putting the family voice at the table in the process of things being developed, and very much appreciate your support with that effort.
Thank you, Lorna. I'll pass it to Elizabeth, then Stephanie.
Hi, thank you, and thank you for the tremendous presentation today. I think it was extremely helpful to clarify what is very confusing for people who are directly working in the system every day. So I appreciate that. And I appreciated that you started the meeting referencing that we're really looking to pull together the different advisory bodies to tackle this is a challenge that we hear in every context of children's services. And so the Children's Behavioral Health Plan Implementation Advisory Board, CBAC, the Children's Behavioral Health Advisory Council, are hosting a joint meeting of all of our membership on May 1st to specifically talk about services for this population, and in line with the Children's Behavioral Health Plan, which really emphasized the importance of a service array for all of Connecticut's children, is recognizing what are perhaps some short-term strategies, some intermediate term strategies, and then long-term system development that we need to do. So I really appreciate the presentation, and I appreciate the opportunity to build upon what we heard today rather than restarting from square one as we continue to talk about this. Thank you.
Thank you. Stephanie?
Thank you. Similar to how Lorna is popping something into the chat, I also wanted to pop something into the chat. There are uh, opportunities that the Link Center often sends to folks. And the Link Center facilitates a shared learning group where they sort of look into different topics, specifically with how to better support people with an intellectual and developmental disabilities, brain injuries, and other disabilities with co-occurring mental health conditions. And these are opportunities that we here at DCF share with our providers to ensure that they're staying informed. So I will put that in the chat. The nice thing about those learning opportunities and those collaboratives is it does split it out into interested populations. So there's one for providers, there's another one that might be for families. So I will put that in the chat if anyone is interested.
Thank you, Stephanie. Are there any other questions or comments? Again, if there are any following this call, please feel free to email me and I can forward them to the presenters and get back to you. But if not, thank you all for coming today. I know it was a lot of information. The updated slides should be in the OneDrive. If you have any trouble accessing them, please let me know. As of now, our next meeting is tentatively scheduled for May 6th. I will be updating that invite tomorrow to May 13th as May 6th is the last day of session. So be on the lookout for that change. And that is scheduled as of now to be a hybrid meeting, both at the LOB and on Zoom. If there's nothing else, I think we are all set for the April meeting. Thank you all again. Thank you to all the presenters. Really appreciate it.
Thank you, everyone, as well.